Hi everyone, my name is Charles Lei and I'm one of the EM faculty at Vanderbilt. In this lecture, we will be discussing the red eye. We will work our way from outside in, starting with the lids and lashes, followed by the conjunctiva, the sclera, the cornea, the uvea, and finally the anterior chamber. Here is the anatomy of the lids and lashes. As you can see, there are several important glands associated with the eyelid and the eyelashes. The meibomian glands are modified sebaceous glands located within the tarsal plates of the eyelids, and they're responsible for secreting the oily layer of the tear film that prevents tear evaporation, reduces the surface tension of the tear layer, and facilitates the spread of tears. The glands of Zeiss and the glands of Mole are associated with the eyelashes and help to kind of keep the eyelashes oily and supple. The first eye pathology that we're going to discuss is Blepharitis, which is inflammation of the eyelid margin. There's usually very little or no ocular involvement. This is a very common chronic ophthalmologic condition that typically involves both eyes and is most commonly caused by meibomian gland dysfunction or by chronic bacterial infection or colonization. So as you can see here on the left side, there is erythema and swelling of the upper eyelid. And then on the right side, you can see that the eyelids have little plugs at the meibomian gland openings. So patients present with a red, swollen, itchy eyelid with crusting or matting of the eyelashes. They may have flaking or scaling of the eyelid skin and a foreign body sensation with some greediness and burning feeling in their eyes. They may have excessive tearing, and they'll often have mild conjunctival injection, although again, there's usually very minimal ocular involvement, and they may have light sensitivity. Treatment is mostly focused on good hygiene, both eyelid and facial hygiene. It's important to avoid any triggers and exacerbating factors, such as allergens, cigarette smoking, and contact lenses while the patient is still having symptoms. If the patient is having mild or moderate symptoms, then they can treat with warm compresses, lid massage, lid washing with warm water or dilute baby shampoo several times a day, and artificial tears. If they're having severe or refractory symptoms, they may require antibiotics, either topical or oral antibiotics. And follow-up is really just with a PCP or a non-urgent referral to ophthalmology. The next case is Hordeolum, or more commonly known as a Stye. This is another very common condition that we see in the emergency department. This is an acute infection of one of the eyelid oil glands. There are several types of hordeola. External hordeola are infections of either the gland of Zeiss or the gland of Mole, whereas internal hordeola are caused by inflammation of the meibomian glands. And this is usually caused by infection by Staph aureus. On presentation, you'll see a localized area of erythema, swelling, and pain to the eyelid. Treatment is with warm compresses. You want to place the compresses on the affected area for 15 minutes at a time, at least 4 times a day. And styes will typically resolve spontaneously within 1 to 2 weeks, and systemic oral antibiotics are rarely needed. But if there's concern for early preseptal cellulitis, meaning if there's more erythema than expected, especially around the eyes, then it is prudent to start oral antibiotics to avoid or prevent progression to preseptal cellulitis. The next is a similar pathology called a Chalazion. This is a chronic granulomatous inflammation of one of the oil glands on the eyelid. It looks similar to a stye, but presents over a different time period. And patients with chalazions usually report a painless, rubbery eyelid nodule. It usually looks a little less erythematous than a hordeolum and can appear over days to weeks. Treatment is similar, though. It is with warm compresses several times a day. These often resolve within 2 weeks. And if they do not resolve, then it might be helpful to refer these patients to ophthalmology, as they might require incision and drainage on an outpatient basis. As you can see here, this chalazion looks different than a stye because of its kind of rubbery nodular appearance. It's a little less erythematous and looks almost just like a little lump on the eyelid. All right. Next, we're going to talk about the conjunctiva. So the conjunctiva is a mucous membrane that lines the inner surface of the eyelid and covers the globe up to the limbus. So the portion that covers the globe is called the bulbar conjunctiva here, and the portion lining the eyelids is called the tarsal or palpebral conjunctiva. The conjunctiva is generally transparent, but it is vascularized, so when it becomes inflamed, as in conjunctivitis, it looks pink or red at a distance. When examined more closely, you can actually discern fine blood vessels, known as injection, in contrast to extravasated blood, which we'll talk about later. All right, in this case, you have a 30-year-old school teacher with no significant past medical history who presents with irritation in one eye, and then after a few days, irritation in the other eye. Both eyes are red with watery discharge. The patient feels miserable. He's also had rhinorrhea, nasal congestion, and URI symptoms. No blurry vision, however, no flashes or floaters or curtains over the visual field, and no contact lens use. On exam, he has normal visual acuity, full visual fields, intact extraocular movements, and his exam is pretty much normal, except for some preauricular lymphadenopathy. On closer examination, you see these tiny avascularized, round, raised white patches located between the blood vessels on the palpebral conjunctiva. And when you instill fluorescein, you see these little follicles under blue light. This is a case of viral conjunctivitis. It's the most common form of infectious conjunctivitis, and it's most commonly caused by one of a number of serotypes of adenovirus. It is spread by hand-to-eye contact, but can also be spread by any sort of contact, such as on tonometers or slit lamps. That's why it's really important to clean these devices after you use them. Patients usually present with eye redness and a mild burning sensation with associated tearing and watery discharge. Classically, it begins in one eye and then spreads to the other eye after about 3 days. There's usually no change or decrease in visual acuity. And as I mentioned earlier, you see follicles on slit lamp and fluorescein examination. Treatment is mostly supportive. You can prescribe preservative-free artificial tears up to 8 times daily to help with lubrication. It's important to avoid steroids in general, but if there's concern for other issues, then such as epidemic keratoconjunctivitis, then steroids may be administered, but only after discussion with ophthalmology. Contact precautions are really important, as viral conjunctivitis is extremely contagious. So encourage frequent hand washing, using separate tissues and towels and pillows, and disinfecting surfaces. And follow up with primary care. However, in folks who wear contact lenses, it's important to have them follow up with ophthalmology, even though this is just viral conjunctivitis, because you want to ensure that their conjunctivitis is not actually an early form of bacterial keratitis. Also, if there is significant photophobia, any decreased visual acuity, or conjunctival injection that remains unilateral, then it's important to follow up with ophthalmology. I mentioned epidemic keratoconjunctivitis. This is caused by several specific serotypes of adenovirus. This is also highly contagious and tends to occur in epidemics, hence the name. And it causes both conjunctivitis and keratitis, which is an inflammation of the cornea. Patients will present similarly, except they will have visual acuity deficits and may actually have decreases up to 2 to 3 lines on the Snellen chart. And these folks specifically are treated with a long taper of topical steroids. So if there's concern, you definitely want to talk to ophthalmology first before starting steroids. All right, our next case. This is a patient who presents with crusting of the eyelids and difficulty opening the eyes in the mornings for the last 3 days. Started in one eye and after 1 to 2 days developed in the other eye. Little to no itching. It's been getting worse and the patient does not wear contact lenses. On exam, you see significant mucopurulent discharge and no preauricular lymphadenopathy. This is a case of bacterial conjunctivitis. It is most commonly seen in children and in the elderly. And it presents as thick, purulent discharge with conjunctival injection and chemosis, which is swelling of the conjunctiva. It's more likely to be monocular than binocular, so that's one way to potentially differentiate it from viral conjunctivitis. And visual acuity is generally unaffected. Patients are usually systemically well. And there are a number of different organisms that can cause bacterial conjunctivitis, including staph, strep, Haemophilus, Moraxella, Pseudomonas, specifically in contact lens wearers, and then gonorrhea and chlamydia, which we'll talk about separately. In patients who have bacterial conjunctivitis and are not contact lens wearers, the treatment involves good hand hygiene to minimize spread and infection to the other eye and to other people, and then good eye hygiene to minimize secretion buildup. You can also prescribe erythromycin ointment to be used 4 times a day for 7 days, as well as trimethoprim polymyxin B drops or Polytrim to be used 4 times a day for 7 days. And it's important for these folks to follow up with ophthalmology in 2 to 3 days. For contact lens wearers, there's a significant concern for Pseudomonas, and so first-line treatment involves fluoroquinolones, such as ofloxacin, 4 times a day for 7 days. These patients should be instructed to discard their soft contacts, to not wear contact lenses until 24 hours after antibiotics are completed and the infection has resolved, and to also discard or thoroughly disinfect their contact lens case. And urgent follow-up with ophthalmology is really important to make sure that the conjunctivitis is not an early bacterial keratitis. So here are some of the medications that can be prescribed for conjunctivitis. I encourage you all, if you don't already have it, to download the app GoodRx, which can give you a good idea of how much these medications would cost and where they might be the least expensive, such as Walmart or Costco. This is a case of hyperacute conjunctivitis due to Neisseria gonorrhoeae. The baby on the left started having bilateral purulent discharge 3 to 5 days after a vaginal delivery. The patient on the right started having copious amounts of purulent discharge that forms quickly after wiping it away, and there's significant conjunctival injection, chemosis, eyelid swelling, globe tenderness, and preauricular lymphadenopathy. Both patients are infected with Neisseria gonorrhoeae, and in the newborn, this is called ophthalmia neonatorum. All right, so the The baby on the left presents with tearing, conjunctival injection, eyelid swelling, and moderate discharge 5 to 12 days after birth. The patient in the middle is from the Sudan and has had an eye infection for months. There's scarring of the tarsal conjunctiva, suggesting trachoma, especially if seen in endemic areas, or the scarring is linear and if there's corneal vascularization. The patient on the right has unilateral redness, foreign body sensations, mucopurulent discharge, preauricular lymphadenopathy, and follicles heaped on follicles, as you can see. These patients are all infected with Chlamydia trachomatis. The treatment is combined because folks who are suspected to have Neisseria should also be treated with antibiotics for Chlamydia and vice versa. So the treatment for Neisseria in neonates, the first-line therapy is either cefotaxime or ceftriaxone. It's important to keep in mind that ceftriaxone should be used with caution in infants with significant hyperbilirubinemia, as it can lead to encephalopathy. And so if there's concern for that, then use cefotaxime rather than ceftriaxone. These patients should have their eyes irrigated frequently, and they should be admitted for monitoring. In adults, the first-line therapy is 1 gram ceftriaxone, which can be given intramuscularly or IV. If there's any corneal involvement, then treat with ceftriaxone 1 gram twice daily, as well as a topical fluoroquinolone. Again, you also want to treat for chlamydia and then admit for observation. For chlamydia, the treatment is with topical erythromycin. In neonates, they should also receive oral erythromycin elixir, and then adults get 1 gram azithromycin or erythromycin for 7 days. Patients with trachoma either receive azithromycin for 1 dose or tetracycline ointment for 6 weeks. In this next case, the patient presents with red eyes, itching, and clear, watery, or even ropey discharge. They have a history of asthma, eczema, and allergic rhinitis. On examination, there is eyelid edema and conjunctival edema, or chemosis. It's bilateral, and when the eyelids are everted, you can see these large papillae, and you can see raised white dots at the limbus. And on fluorescein stain, the papilla, you can see papilla with thick white, sticky, ropey discharge between the papillae. This is a case of allergic conjunctivitis, which is the most common cause of conjunctivitis overall. Treatment is with cool compresses and preservative-free artificial tears. You can also prescribe antihistamines or mast cell stabilizers, and steroids can be prescribed, but only after consultation with an ophthalmologist. And follow-up is with primary care. All right, so this is subconjunctival hemorrhage. It's a usually benign process that's associated with traumas, and it could be minor trauma such as eye rubbing or a foreign body, or even something like coughing or straining or Valsalva. It's commonly seen when patients are using anticoagulants or antiplatelet agents. Patients usually present with isolated, unilateral, and well-circumscribed area of blood located under the conjunctiva at the limbus. That's stopped at the limbus. There's usually no pain or inflammation or eye discharge associated with this condition, and no vision deficits. And really, no specific treatment is needed. If the patient is on something like Coumadin, then it might be important to check an INR. You can prescribe lubricating drops if the patient is reporting grittiness or dry eye symptoms, and this should spontaneously resolve within 2 to 3 weeks. But if the condition worsens or the patient develops pain, then refer to ophthalmology as an outpatient. All right, next we're going to talk about conditions related to the sclera. And in this diagram, you can see the relationship between the episclera and the sclera. The episclera is a fibroelastic structure that is made up of two layers closely joined together, and each layer contains blood vessels that originate from the anterior ciliary arteries, and the episclera sits superficial to the sclera. So in this case, you have a young adult with mild pain in one eye. They have a grittiness and foreign body sensation in the eye and a dull headache. On examination, the patient has normal visual acuity and normal visual fields and a mild watery discharge. And you see on exam a focal area of redness, or actually a nodule kind of located over the conjunctiva. This is episcleritis, and episcleritis is an inflammation of the episclera. It's most often idiopathic and most commonly seen in female patients and most commonly in the 5th decade of life. It could be associated with systemic autoimmune conditions such as rheumatoid arthritis or lupus. And the presentation is key here. So it's usually an abrupt onset of unilateral focal eye redness in the interpalpebral zone, so the zone that's visible when the eye is open. You see mild irritation of the eye, and there's usually no tearing and no vision changes. On exam, you see these inflamed vessels. And the way to diagnose it is that these vessels should be movable or mobile when you apply gentle pressure to the vessels with a cotton-tipped applicator. So, you put the cotton-tipped applicator onto the vessels and just gently try to move the vessels up and down, and they should kind of slide with the applicator. Also, when topical phenylephrine is applied, these vessels constrict. And the treatment here is with topical lubricants to avoid that grittiness. You can also prescribe either topical or oral NSAIDs. This condition usually resolves spontaneously in 2 to 3 weeks without intervention and self-limiting. It's important to provide follow-up and with PCP and return precautions for scleritis. All right, so this next case, you have a middle-aged female with gradual or acute onset of severe boring eye pain that radiates to the forehead, jaw, and scalp. On exam, you see these engorged, inflamed scleral, episcleral, and conjunctival vessels. And when you try to move the vessels with a cotton-tip applicator, they don't move. And when you apply topical phenylephrine, the vessels don't blanch. And you see this sort of blue hue to the sclera. So this is a case of anterior scleritis, which is an inflammation of the sclera. Like episcleritis, there's a female predominance, and about half of the patients have associated autoimmune disease. These patients present with unilateral eye redness with engorged scleral vessels, and they usually complain of deep, boring pain that wakes the patient from sleep. That's a classic presentation. And you'll see this blue hue to the sclera, which is actually thinning of the sclera. And they may have decreased visual acuity. And unlike episcleritis, you can't move these vessels with a cotton-tip applicator, and the vessels do not blanch. So in the workup of scleritis, you want to discuss the case with ophthalmology. That's really important, and then also send a bunch of these labs to look for autoimmune conditions. Occasionally, scleritis can be caused by infection, And so this is another reason to consult ophthalmology, as they may perform scrapings of the conjunctiva for smear and culture. So again, really important if you're worried about scleritis to discuss the case with ophthalmology and have them evaluate the patient in the emergency department. Treatment is usually with NSAIDs, corticosteroids, and systemic immunosuppression. And most commonly in the emergency department, you'll start an NSAID and have the patient follow up with ophthalmology in 1 to 2 days. All right, next we'll talk about pathology related to the cornea. Here's the cornea, which is the kind of transparent layer in the anterior eye that sits over the visual axis, and it's a continuation of the sclera, as you can see here. So the first case is a corneal abrasion. This is a defect in the corneal epithelium, and it's usually associated with trauma, with or without a foreign body. And it's really important when you see patients with a potential corneal abrasion that you evaluate for open globe keratitis, which is a corneal ulcer, retained foreign body, and hyphema. These patients usually present with burning eye pain, a foreign body sensation with grittiness, and photophobia. And if the corneal abrasion is sitting directly over the visual axis, they may have decreased visual acuity. To make the diagnosis, you want to measure the vital signs of the eye, including visual acuity, and you want to make sure to exclude open globe. So the fluorescein stain is going to be extremely important here. You should see if there's a corneal abrasion, you'll see the fluorescein stain a sort of patch over the cornea. And you want to look for a Seidel sign, which is a sign of open globe. So when you apply fluorescein, you'll actually apply it to the defect and look for streaming of fluorescein caused by leaking of the aqueous humor. It's really important to avert the eyelids, looking for a retained foreign body, because that could be the culprit causing the corneal abrasion. Treatment is typically with topical antibiotics, such as erythromycin or polytrim. Ointments are theoretically better than drops because they also function as a lubricant. And for contact lens wearers, it's really important to cover for Pseudomonas, so you'll start a fluoroquinolone, such as ofloxacin or ciprofloxacin, or you might give a tobramycin or gentamicin. You want to make sure to provide pain control with oral or topical NSAIDs, and you might want to prescribe cycloplegics, such as cyclopentolate, to prevent further pain. Patching is very controversial and usually not necessary. For the really small, uncomplicated corneal lesions, it's completely unnecessary. And in folks that are contact lens wearers, it's actually contraindicated because it can create a dark and warm and humid environment that may be more conducive to the growth of microorganisms, and so overall patching is not needed. You want to make sure that they follow up, and they should follow up with ophthalmology in 1 or 2 days if they are a contact lens user, if there's a large abrasion over the visual axis, or if the abrasion hasn't healed after several days. The next case is, or the next set of cases involves infectious keratitis, which is an infection of the cornea, and there are multiple different organisms that can cause infectious keratitis, including bacterial, viral, fungal, and amoeba infections. So the first is bacterial keratitis, which is commonly known as a corneal ulcer. This presents as a painful red eye with photophobia. Patients usually have mucopurulent or purulent discharge, and will report decreased visual acuity. When you examine the patient, even without fluorescein, you might actually see the corneal opacity, indicating that there's an ulcer there, especially if the lesion is more than about half a millimeter. You should be able to spot it with just a pen light. Patients may present with a hypopyon as well, and it's important to know if they have a history of contact lens use or immunosuppression. So the treatment is with broad spectrum antibiotic eye drops every 1 hour. So either cefazolin combined with aminoglycoside or a fluoroquinolone with or without tobramycin. It's also helpful to prescribe a cycloplegic, which will help to reduce pain and photophobia from ciliary spasm, and also help to reduce the formation of adhesions on the lenses. It's important to instruct patients to throw away their contact lenses and their contact lens case. If the corneal ulcer is deep, this is one instance where a hard patch or a shield might be helpful to prevent perforation. And these patients should get ophthalmology consultation in the emergency department, as well as close follow-up in the next 1 to 2 days. All right. In this next case, you have a 30-year-old teacher with no significant medical history, presenting with eye pain, redness, photophobia, foreign body sensation, and a watery discharge. The symptoms started yesterday. The patient doesn't wear contact lenses and has no history of allergies. On exam, you see this conjunctival injection, slightly diminished visual acuity in the affected eye, on slit exam, you see follicular conjunctivitis. Sounds like conjunctivitis, right? But this is actually a case of viral keratitis caused by HSV. This case is the reason why it's so important to perform a full exam of the eye in patients who come in even with something as simple as viral conjunctivitis, because it could be something else. And so it's important to obtain all the vital signs of the eye and to perform fluorescein staining. So in this case, the patients will present with pain, tearing, photophobia, and will have decreased visual acuity. And on fluorescein stain, you see these epithelial defects with branching pattern, with terminal bulbs known as dendrites. And this is classic for HSV keratitis. Treatment is with antiviral eye drops, and you also will prescribe oral antivirals such as acyclovir. And this is important because HSV keratitis can progress from epithelial involvement to stromal involvement, which will lead to neovascularization of the cornea and then ultimately blindness. And that's why oral antivirals are helpful. And then you also want to prescribe a cycloplegic if there is photophobia or anterior chamber reaction. And it's important to have the patient follow up with ophthalmology within 24 hours. The next case is Zoster Ophthalmicus. This is caused by varicella zoster. And about 10 to 25% of zoster infections involve the eye. Corneal disease usually follows the skin rash by about several days to even several months. But occasionally, the eye infection can precede the skin rash, and maybe the initial presentation or only presentation of a zoster infection. Hutchinson sign is important to know. Patients with varicella zoster keratitis will often have a characteristic vesicular rash in the nasociliary branch of the V1 or ophthalmic division of the trigeminal nerve. And if the nasociliary nerve is involved, it is likely that the patient will have corneal involvement. So it's important to look for pustules or lesions at the tip of the nose, which might indicate that there is corneal involvement. This sign is neither sensitive or specific, but helps in your diagnosis. On fluorescein stain, you'll see something similar to HSV keratitis. You'll see these branching lesions, but they will end in sort of these tapered ends, not bulbs, and these are called pseudodendrites. So the treatment for Zoster Ophthalmicus is kind of separated into treatment of skin lesions and treatment of ocular lesions. So for skin lesions, you'll prescribe either acyclovir or famciclovir or valacyclovir to be given orally, as well as bacitration or erythromycin ointments. For the ocular lesions, treatment really depends on sort of what's involved, but you'll usually give a prescription for erythromycin ointment, artificial tears, and then topical antiviral treatments. These patients may require steroids, but you will only give it in consultation with ophthalmology. For patients who are over 6 years, it's important to also administer the varicella zoster vaccine, and patients should follow up with ophthalmology within 24 hours. All right, in this next case, both patients present with eye pain and redness. The patient on the left was kind of welding without a mask, and the patient on the right was hiking in the snow without sunglasses. This also happens to patients who are not wearing appropriate eyewear while tanning in a tanning booth. Both of those patients have UV keratopathy, and what happens is that the UV rays will irritate the superficial corneal epithelium and cause inflammation of that epithelial layer and damage to that layer. And patients will present with eye pain, redness, a foreign body sensation, tearing, and photophobia. These symptoms usually develop 6 to 12 hours after the injury. And on fluorescein stain, you see these sort of punctate lesions in the interpalpebral distribution, so in the area where the eye is open. Treatment includes artificial tears and cycloplegics, as well as topical NSAIDs. And these patients will follow up with ophthalmology in 1 day, and symptoms should resolve in the next several days. All right, next we'll talk about the uvea. And the uvea consists of 3 structures, the iris, the ciliary body, and the choroid more posteriorly. The next case is Anterior Uveitis, and this is an inflammation of the uvea, and it's most commonly caused by systemic diseases, infections, certain drugs, and trauma. And on examination, these patients will present with kind of deep aching pain that's worse with extraocular movements. You'll see significant eye redness and injection, most pronounced at the limbus, which is the interface between the conjunctiva and the cornea. So you see here, the eye is extremely red right at the limbus. These patients will usually have direct and consensual photophobia. The pupil may be constricted, irregularly shaped, and or sluggish, and they often present with decreased visual acuity. On slit lamp exam, you'll see cell and flare, and this is an indication that there's inflammation within the anterior chamber. So the cell refers to circulating immune cells in the anterior chamber, and flare is caused by protein leakage into the anterior chamber from inflamed blood vessels. You may also see a hypopyon in the setting of anterior uveitis, and this is the settling of white blood cells in the anterior chamber to form a level, like kind of a fluid white cell level. And this is usually associated with significant infection or inflammation, such as uveitis or infectious keratitis or endophthalmitis. Treatment for anterior uveitis involves emergent ophthalmologic consultation, so they definitely need to be seen by ophthalmology in the emergency department. And these patients will usually be treated with cycloplegics and steroids, with follow-up with ophthalmology in 24 hours. All right. Next, we'll talk about the anterior chamber. So the anterior chamber is kind of the fluid-filled chamber that sits just anterior to the iris and deep to the cornea. This is a hyphema, which is blood in the anterior chamber. It's commonly caused by trauma, but can occur spontaneously in patients who have clotting disorders or are on anticoagulants. On exam, you'll see a distinct blood fluid level in the anterior chamber. Some patients have microhyphemas, so the red blood cells are actually dispersed within the anterior chamber and don't layer out, and you may not see it unless you perform a SLEM exam. These patients will often describe photophobia and decreased visual acuity, and they may have anisocoria. They may have elevated intraocular pressure, and the cornea may actually be stained by blood if the hyphema has been there for a little while. It's important to look for injury to adjacent structures, such as evidence of an open globe, corneal abrasions, traumatic iritis, or lens dislocation or subluxation. There's a grading system for hyphemas, and it goes from grade 1 to grade 4, depending on the percentage of the anterior chamber that's filled with blood. So in this top image, this is a grade 1 to 2 hyphema. As you can see that it's kind of is less than 50%, maybe more than 33% filled with blood. And then in the bottom image, this is a grade 4 hyphema. As you can see, the layer of blood is pretty high up, almost 100%, and definitely affecting the visual axis. So treatment starts with assessing for and treating any sort of life-threatening traumatic injuries, and also treating any underlying blood dyscrasias. It's important to place an eye shield over the affected eye and raise the head of the bed to 30 degrees, control nausea and vomiting, and do everything that you would normally do for elevated intracranial or intraocular pressure. You'll treat with cycloplegics, which will help with the pain, and administer topical or systemic pain medications as needed for symptomatic relief. And these patients warrant prompt ophthalmology consultation in the emergency department. All right, in this case, we have a 19-year-old college student with bilateral blurry vision and eye pain. They recently had sinus congestion and a cough and took some Dayquil, and they've been studying for an exam and developed blurry vision and a mild headache. The pain developed in both eyes, and the patient has noticed halos around the lights. And they've also had nausea and vomiting. On examination, they have decreased visual acuity bilaterally. The pupils are mid-dilated and sluggishly reactive. There's a steamy cornea, and there's conjunctival injection. Intraocular pressure is 40 bilaterally, and the patient has no other neurologic deficits. This is a case of acute angle closure glaucoma, and as it sounds, it's caused by closure of the angle in the anterior chamber, resulting in kind of elevated intraocular pressure because the aqueous humor can't leave the anterior chamber, and ultimately can lead to optic nerve damage as the intraocular pressure rises. So as you can see here, this is what the normal anterior chamber should look like, with a wide angle here, or an open angle. And here you see a closed angle or narrow angle, and this is, puts the patient at high risk for angle closure glaucoma. Patients will present with ocular pain and decreased vision. They will have photophobia and report halos around the lights. They may have associated headache and nausea and vomiting. And on exam, they'll have diffuse eye redness with ciliary flush, a mid-dilated sluggish pupil and a hazy cornea, and elevated intraocular pressure, so something above 20. And treatment really involves emergent ophthalmology consultation and frequent eye drops. So patients who present with concern for acute angle closure glaucoma should get emergent consultation in the ED. And then it's important to start a number of medicines, including a topical beta blocker such as Timoptic, an alpha-2 agonist such as brimonidine, a topical prostaglandin such as latanoprost, as well as a number of other medications. And these are usually drops that are given every 15 minutes for several rounds while waiting for ophthalmology to come down to the ED to evaluate the patient. And these patients will also may also get acetazolamide and or mannitol. And disposition is really going to depend on whether the patient's intraocular pressure remains persistently elevated or improves with these rounds of eye drops. If the intraocular pressure does not successfully go down to a normal range, or if they have bilateral glaucoma from some sort of medication-induced angle closure, or if they can't tolerate oral medications, then consider admission. If the patient is discharged, then it's important for them to follow up with ophthalmology in the next 24 hours. All right, thank you very much for listening to this lecture, and please do not hesitate to email or contact me with any questions.